So the next speaker for the session is Dr. Neha Dangayach. She is an associate professor in the Department of Neurology and Neurosurgery at the SIINAI Hospital in USA. She is also serving as a systems director for neuroemergencies management and transfers. She is the research director for neurocritical care and recovery and also the co-lead for the MSH Wellness Committee. She is an editor for neurology clinical practice, editorial board member in CHEST as well as in critical care medicine, and an associate editor for stroke, vascular, and interventional neurology. She was awarded the Toba Pasek Award for Teaching Excellence in Neurosciences by the Department of Neurology at SIINAI in 2017. She was also awarded the Neuroscience Physician of the Year for SIINAI Hospital in 2019. So Dr. Neha is going to talk to us about balancing hydration and osmolarity in neurocritical care patients. I think this is very important from a clinical perspective, and it would be great to hear Dr. Neha's perspective. So Dr. Neha, if you are online, you can take over.
Sure, thank you. Thank you so much for the kind introduction. I am on service, so pardon the noise in the background. And hopefully we don't have to cut the presentation short for an emergency, but barring emergencies, I'm here. So thank you so much for the invitation. And the reason why I titled the talk Fluid Stewardship, because this whole balancing act is really about fluid stewardship in a lot of ways that we learn from the International Fluid Academy as well. And how do we apply that to our patients with severe acute brain injuries? I do have a few disclosures. None of them will relate directly to what I'm going to talk to you about today. For several of you as intensivists, you're going to end up taking care of patients with different kinds of brain injuries. As you scan this slide from left to right, all of these patients are going to need a very close monitoring of their fluid balance, of their osmolarity, and as a bridge to definitive therapy. So how do we do that in a meaningful manner? In the neuro ICU, often we're meeting these patients when they've had their primary neurological injury, and the goal of all of our therapies is to really rapidly treat that primary injury, monitor closely for secondary neurological injuries like worsening cerebral edema, status epilepticus, and make sure that we're preventing systemic injuries. But all of that together is going to help us optimize our patients' outcomes as well as prepare them for that new state of normal. Neuro ICUs and also ICUs that take care of neurocritical care patients tend to become very data-rich environments. And we use a lot of different monitoring strategies, both for the body and the brain, including invasive, non-invasive monitoring. Despite all of that, measuring the volume status for systemic volume status, as well as the volume status of the brain, is very, very hard. Just a couple of case examples, and you've all probably taken care of these kinds of patients, right? So here's a patient. The first scan that I'm showing you up here is a patient with a left basal ganglia hemorrhage, and then this patient has a rebleed, the hematoma expands, and the patient slips into a coma. At the bottom scan, we're showing you a patient with a high-grade subarachnoid hemorrhage, Hunton has 5, modified Fisher-4, has bilateral EBDs, and is also in a coma. What is going to be your first line for resuscitating these patients as you're bridging them to get definitive care? Do you use mannitol? Do you use hypertonic saline? What do you do about volume resuscitation after you've given them mannitol? So obviously, just like all emergencies, ABC is going to come first. And as you're resuscitating them, what are you going to use as pre-medication when you secure their airway? Do you reach for hypertonic saline or mannitol in that situation? There's decreased cerebral perfusion, and we want to maintain, we know CPP is equal to MAP minus ICP, so all of our therapies are going to be targeted towards reducing ICP and also maintaining a patient's MAP. Unfortunately, for neither of these patients, for our SH patient whose aneurysm is not secured, we cannot augment their MAP. For that hematoma re-rupture, we cannot, hematoma expansion, we cannot really augment their MAP just yet. So our therapies are going to very much be targeted towards trying to reduce their ICP as much as possible. And of course, you're going to provide some definitive neurosurgical interventions, whether it's CSF diversion, whether it's craniotomies, whether it's minimally invasive clot evacuation, etc. But resuscitation is still going to lean on, is it going to be hypertonic saline, mannitol, combination of the two as a bridge to other therapies? And then after you've done all of that, in that maintenance phase, what do you use for maintaining a patient's intravascular volume? Should we lean on isotonic fluids? Should we use dringalactate, balanced solutions like plasma light, or is normal saline good enough? As a quick recap of the Kelly-Monroe doctrine, this was described over 200 years ago. We know the brain cerebral spinal fluid, blood volume are all sitting in a tight balance in a tight skull. If something increases, then something's got to give way. The brain tries to compensate by increasing venous return when either there is increased mass effect or intracerebral hemorrhage or sinus venous thrombosis. The brain's attempting to not have our patients experience clinical effects of that raised intracranial pressure by increasing venous return and by increasing CSF resorption. But when these compensatory mechanisms are overcome, we know that our patients are going to experience signs and symptoms of raised intracranial pressure. We also know that cerebral compliance, the change in pressure is going to be very much dependent on the change in volume, particularly if it's happening very rapidly. Different types of cerebral edema, whether it's cytotoxic, vasogenic, interstitial, a combination of these, irrespective of what type of edema or combination we're dealing with, the key principle of management is still going to be, I want to maintain cerebral perfusion pressure. CPP is equal to mean arterial pressure minus intracranial pressure. What is this patient's cerebral autoregulatory status? Is there any decoupling? Is there any dysregulation that has happened? And how do we walk up this ladder? At every institution that takes care of patients with different kinds of brain injuries, people try to follow some kind of ladder-based approach to ICP management. And as we go up this ladder, this question of what fluid are we going to use for resuscitation, what fluid are we going to use for that maintenance keeps coming up repeatedly. On the right-hand side, I just show you a recap of how we conceptualize this autoregulation for the brain. And we know that a map between 50 to 150, most of our patients are going to be able to autoregulate and maintain their CPP. But when patients have cerebral dysautoregulation, then you're going to begin to see a more linear relationship between MAP and ICP. So with that, just a quick recap. Dr. Malbrain, Professor Malbrain has probably already alluded to these 7 Ds of fluid management. How do we apply this to patients with various kinds of severe acute brain injuries? The definition, the diagnosis, drug, dose, duration, de-escalation, and discharge. So when I try to apply this concept, this framework, to the concept of severe acute brain injuries, I think we can divvy this up into resuscitation fluids, replacement fluids, and maintenance fluids. While there's a lot to talk about, in the interest of time, I'll focus on ICP and delayed cerebral ischemia for resuscitation. For replacement, sodium and free water disorders like cerebral salt wasting or SIADH-DI that we see in a lot of these patients. And then for maintenance in the peri-procedural period or patients who have dysphagia and you're still trying to figure out enteral access for them, then how do you maintain their intravascular volume? These are a few guideline statements that help us better understand how we can better balance the volume status for a lot of these patients. So the guidelines for severe TBI, the American Heart Association's guideline statement for cerebral and cerebellar infarction with swelling talks about this a lot. Then the guidelines for management of cerebral edema in neurocritical care patients published by the Neurocritical Care Society in 2020 tries to synthesize a lot of this literature. And then fluid therapy in neurocritical care patients, the European Society of Intensive Care Medicine provides a nice synthesis of a lot of this literature. So moving through the definition, diagnosis, drugs, we'll really talk about choosing between hypertonic solutions, hypertonic saline solutions and mannitol, the doses, duration, and de-escalation. The core concept in resuscitation when we're using hypertonic solutions, whether it's hypertonic saline, mannitol, the idea is we're going to try to dehydrate the brain by way of establishing an osmotic gradient along with this tight blood-brain barrier. And how effective an agent is going to be dependent both on what is the underlying etiology, what is the integrity of the blood-brain barrier, what is the reflection coefficient of that fluid, and is the blood-brain barrier fully going to be reflective of it and create an effective osmotic gradient to dehydrate the brain or not? What is your access? Do you have these solutions available? What is the cost? And how quickly can you administer them? Typical doses for various osmotherapies. Just a quick summary of various solutions that can be used in just a comparison with normal saline, which we think of as being slightly hyperosmolar when you think about other isotonic fluids like ringolactate, plasmalite. So the osmolarity of normal saline tends to be a little bit higher than that, and this is going to be important in rest of our discussion as well. In the guideline statement from the Neurocritical Care Society, they essentially acknowledge that the literature we have to help us choose between mannitol and hypertonic saline, the literature quality is not great. And a lot of this literature is smaller studies, retrospective studies, very, very few randomized controlled clinical trials. After acknowledging the limitation of this body of literature, I'd like to highlight that no matter what you choose, it's important to choose what you have available. Make sure that you pick the right dose and make sure you're using the right route. When we compare salt versus sugar, so mannitol, of course, is a sugar. Various concentrations are available. You should be aware of what concentration you have available. In India, for the most part, you don't run into this issue of crystallization unless you're in a region that experiences colder temperatures, but crystallization of mannitol. So make sure that your mannitol is stored in a warmer. What are the usual doses? You're going to do 0.5 right up to 1.5 grams per kg. You're going to use a filter. You can bolus via a peripheral IV. Yes, the onset is relatively quick, but not as fast as hypertonic saline. Hypertonic saline can act as fast as 5 minutes. The peak onset is going to be variable for hypertonic saline, but mannitol peak onset will be seen in almost up to an hour. And we see the duration of action. You may need to redose mannitol. With hypertonic saline, you'll have a longer effect. The side effects or adverse effects from both of these in some ways are similar. Yes, you can see volume overload. Yes, you can see worsening renal function. So I'll often recommend doing BMPs or your basic metabolic panels Q6 hours, measuring your serum osmolarities more frequently, making sure that you have ways of monitoring volume status. Of course, a Foley is a simple way of doing that. You've got strict isonos. But caution particularly for hypertonic saline, depending upon the concentration you're using. We end up using these bullets of 23.4%, 30 cc's. When we're giving these bullets, patients can become bradycardic and hypotensive. So I'll give about 5 cc's of that 30 cc, see what happens. I'll have a pressor in the room and verbalize to my team that this is the blood pressure goal we'd like to maintain for this patient. And we'll up titrate either their Levophed or their Cleverprex or their Cardine, which is a calcium channel blocker drip, just to make sure that we're not causing secondary neurological injury while we're trying to resuscitate a patient. What about bolus versus continuous drips? So the COBE trial that looks specifically at traumatic brain injury patients or moderate to severe TBI patients, the bottom line here was continuous infusions of hypertonic saline do not lead to better outcomes as compared to standard of care. This is very much in line with how various guideline statements that I showed you advise using hypertonic saline or mannitol as part of your resuscitation strategies. Rather than doing a continuous drip, use boluses guided by clinical examination or radiographic changes, but have a trigger rather than trying to use continuous drips. What about sodium bicarb? It's available in our crash carts. It's much cheaper to use. How about sodium bicarb? It's also a hypertonic solution. So if you used about 3 amps of sodium bicarb, you could very well have a similar effect in reducing your ICP as compared to using a 30 cc bullet of 23.4%, which is much more costly. Using bicarb, there's a little bit of caution, right? Yes, there may be some increase in your carbon dioxide. In most of these patients, we do want to end up hyperventilating, at least transiently, till they go for definitive management. So here's just another way of conceptualizing it. When you're looking at equi-osmolar doses, how much do you end up giving? Whether you're comparing 3% regimens, 5%, 7.5, whatever you have available, as compared to how many vials. Our vials are 50 cc's or 50 MEQs. So we end up giving 2 to 3 vials of sodium bicarb if we want to use that hypertonic as a hypertonic solution. This is a summary from the Neurocritical Care Guidelines. My take on this, irrespective of the underlying brain injury, if you reached for hypertonic saline over mannitol, the answer might be right. Not because there's a lot of high quality data to guide it, but because there's expert consensus around it, and we know that we're going to get a more sustained effect on our ICP management. And some of these hypertonic saline solutions can also provide some positive inotropic effect. They may help us in augmenting some of that cerebral perfusion pressure anyway. And hypertonic saline can also help stabilize the blood-brain barrier. So that may be a good reason why you may prefer to use a hypertonic saline solution. So going back to our conceptualization, so far we've been talking about resuscitation. We've spoken about hypertonic saline. We spoke about mannitol. One key problem we all run into when we're using hypertonic saline or even normal saline, we know there's going to be NAGMA, non-anion gap metabolic acidosis, hyperchloremia, and hyperchloremia is bad for various reasons, but particularly because you may go into this vicious cycle with renal vasoconstriction and your patient may develop AKI, and now we're just chasing our tails in addition to all the other problems with volume overload. In our patients with subarachnoid hemorrhage, what about that triple H therapy? Augment their blood pressure, make them hypovolemic, hemodilution. Should we be doing a triple H therapy? The simple answer is no. We want to use targeted precision therapy because some patients are just not going to tolerate volume augmentation. You don't want hypovolemia. You want to target euvolemia, not hypervolemia. And I just want to highlight to you, a lot of this data comes from studies which are small. They're not very large studies, but nevertheless, we don't want to cause harm. And using a targeted approach or multimodal approach is better, and precision resuscitation is better than trying to say we're going to make everybody hypervolemic. This is one of my favorite figures from the International Fluid Academy. Fluid overload is a very complex problem, and you run into this vicious cycle for all organ systems, including the brain. So you want to be careful as much as possible and use multimodal monitoring, including your point of care ultrasound, your strict eyes and nose. If you have invasive, non-invasive monitors, use all of that data to guide you appropriately. So looking at that maintenance therapy in neurocritical care patients, what do we know? What should we use? Should we use albumin? Should we use normal saline? Again, I want to point out to you, a lot of these studies are not very large, robust studies. And a key thing in interpreting this literature, we're looking, in some studies, we look at a physiological marker that, hey, did these patients develop more acidosis? Did they get more volume overloaded? And then in other studies, we're using functional outcome measures, did mortality differ, etc. What we know from using all the, looking at the synthesis of this literature, it's important that we're using isotonic solutions rather than hypertonic solutions for maintenance therapy. In this study, again, small study in subarachnoid hemorrhage patients, this study looked at using saline-based fluids as compared to balanced solutions. And what did they find? No surprises. They found, yes, those patients became more hyponatremic, became more hypochloremic, and but they had lesser likelihood of having. So when you look at their serum chloride concentrations, again, no surprise. Serum osmolarity, on the other hand, was a little bit higher in the saline group as compared to the balanced. I know other speakers have probably already alluded to both of these landmark trials, SALT-ED and SMART ICU. Doing this sort of, it was a very, very smartly designed RCTs, but not meant for severe acute brain injury patients, but we'll just look at our subgroup analysis. And here we know that in all comers, in patients from different ICU patient populations, they found that these patients may have a better outcome if you used balanced solutions. But when we drill down on neurologic patients and specifically traumatic brain injury patients, balanced crystalloids were not favored, particularly in traumatic brain injury patients. Saline was better. But neither of these trials was meant to answer this question. What about other larger trials that have looked at balanced solutions versus normal saline? So BASICS told us, well, conducted in 75 ICUs in Brazil, that there's no difference in outcomes, and normal saline is so much cheaper than balanced solutions that we must just use normal saline. And when you look at the subgroup analysis, also in balance with traumatic brain injury patients, we know that it favors saline. Again, BASICS was also not meant to answer that question. Should we use balanced solutions in severe acute brain injury patients, or should we use normal saline? But the subgroup analysis gives us pause. It tells us that balanced solutions may potentially cause harm in our patients with severe acute brain injuries. And when we look at the trends, whether it's serum sodium, whether it's chloride, whether it's bicarb, your creatinine, again, in our group with saline, and this is a pooled analysis from various clinical trials, but included not all severe acute brain injury patients, only traumatic brain injury patients. We've already looked at this. So just as a reminder, we're not using colloids. We're going to use isotonic solutions. And what I've just shared with you are subgroup analysis, mostly in traumatic brain injury patients, but we should use normal saline perhaps in those patients. And what about delayed cerebral ischemia, triple H? Again, reminder, we're not going to be doing triple H in those patients. This meta-analysis of various randomized controlled clinical trials, some of which we've already spoken about, was just published on the 8th of October. Again, we're seeing that saline is better. So fluid management in neurocritical care, use crystalloids as your first line of therapy for maintenance. Don't use colloids or hypertonic saline for volume resuscitation. But for cerebral edema, for ICP crisis, yes, we're going to use hypertonic saline. We're not using central venous pressure monitoring often in these patients, but use multimodal monitoring in these patients, whether you're using your ALAN, your POCUS, your fluid balance, your repeated labs, etc. But the most important message that I want to leave you with, that we really cannot be dogmatic, because none of these trials were robust to answer the question that we want to get at. What is the right fluid to use for resuscitating patients with different kinds of brain injuries? There's a lot of extrapolation from traumatic brain injury studies, but hypertonic saline should be fine. And for now, we need to be judicious in our volume resuscitation approach. So you've got to use the right dose at the right time, right duration for the right indication, de-escalate as soon as you know that your patient has stabilized. What I mean by that is currently we don't have any good studies to tell us how quickly should you reduce. Once a patient's undergone their decompressive hemicranie, or once a patient's undergone, they have, they're past their acute phase for cerebral edema, worsening, whether it's that basal ganglia hemorrhage patient or that subarachnoid hemorrhage patient, how quickly should you let their sodium normalize? We don't have any good studies to guide us. So we just use clinical gestalt and make sure that you're using multimodal monitoring. And for replacement and maintenance, now my first line is normal saline. Years ago, I used to say, there's nothing normal about normal saline, and I would always lean on balanced solutions, but I've changed my practice for that. So thank you so much for having me. I'm going to stop sharing my screen and see if there are any questions.
Thank you, Dr. Neha. Excellent talk. Really enjoyed listening to you. Kind of covered all the clinical aspects of fluid therapy in neurocritical care. So while we invite the participants to type in the questions, if I can ask you in the meantime, in critical care, especially neurocritical care and in subarachnoid hemorrhage especially, we talk a lot about euvolemia, right? You want the patients to be euvolemic. You do not want them to be hypervolemic. Hypervolemia is kind of gone out of practice nowadays. But how do we actually achieve euvolemia? Means, do you look at certain numbers at the end of the day saying, okay, he's 500 cc's positive, so he's euvolemic? So this is something that I find quite challenging at the bedside. How do you actually say that, okay, my patient is euvolemic?
It's such an excellent question. That's probably one of the hardest things to answer. So my approach to figuring out someone's volume status is obviously going to be dependent upon, I'll take the example of aneurysmal subarachnoid hemorrhage. There's so much heterogeneity in how these patients present. On one end of the spectrum, you have patients who are low grade, who are awake, alert, who can drink to thirst. They are ambulating around the unit, and you're monitoring them for delayed cerebral ischemia. And then on the other end of the spectrum, your high grade subarachnoid hemorrhage patients who are in a coma, who are mechanically ventilated, who may have Takotsubo cardiomyopathy, and now that patient goes into delayed cerebral ischemia. What can we do to ascertain volume status? In patients who are who are relatively well and low grade, we don't end up using the same intensity of monitoring. We're relying on simpler measures to give us a sense of whether what is their volume status. So we'll obviously look at, their daily weight, so strict I's and O's. If a patient is totally awake, alert, we may even, we may not even use a Foley catheter. We'll just ask them, pee, and then we'll just ask our nurses to give us, the I's and O's. We look at labs at least daily in those patients, because about 50 or so % of these patients will develop sodium-free water problems, no matter what the grade of subarachnoid hemorrhage is. But Riddhi, I am as stumped by volume status in these patients as you're describing. This is a very difficult problem. In high-grade SH patients, we may choose to lean on, okay, we're doing focus, we'll get different focus measures a bunch of times. I see there's a question about VEXs. Great question. We haven't really used VEXs as regularly as, I would like to. We're still learning how to do the VEXs index correctly, and we'll have we'll go to the bedside, use that in the context of our interpretation, but using some of those, whether it's your IVC collapsibility, and then of course this concept of, is the patient going to be fluid tolerant? Is it safe to even give them volume? Are they, do they have pulmonary edema? Do they have RV dysfunction? So I think all the other, I bet you that everybody else who's also spoken about volume status acknowledges like this stuff is so hard. The same thing applies to our patients with aneurysmal subarachnoid hemorrhage. So one key thing that we'll keep in mind, where in the journey along their vasospasm, delayed cerebral ischemia monitoring journey is this patient. If they're smack in the middle of their vasospasm window, that window is opening at day 3 to 4, day 7 to 10, and they're florid vasospasm, then in those patients, it becomes a little bit, I would say, forgiving. If the patient can tolerate volume, if you end up being a little hypovolemic, I guess it's okay. And then there are much older studies that also talk about augmenting the hypothalamic pituitary axis in these patients, right? Using some steroids, and different regimens have been used, whether you're using stress dose steroids or decadron or a combination of florinef and decadron. You could do all of that and still not have a perfect answer, but you go by the clinical indication for why you're targeting a certain volume status. So if they are improving from their vasospasm / delayed cerebral ischemia perspective, then there are times when, you give 17 liters in and a patient pees out 17 liters, their kidneys are fine, right? So they're not going to hold on to all that volume. Then I will ask my team, hey, let's allow this patient to be 1 liter to 2 liters negative. It's okay, because we're just chasing our tails there. So I know I didn't give you a very satisfactory answer. I'm just like, you just have to do it on a precision.
Yeah, I think that is the essence, because you have to, at the end of the day, you have to individualize to what kind of patient you're dealing with and what are the concerns for that particular patient. And you talked about normal saline over Ringer's lactate. Like most of the recent literature kind of is favoring normal saline over Ringer's lactate. So do you think that is because the Ringer's lactate is slightly more hypotonic and probably is causing more brain edema, possibly more brain injury? That is kind of overwhelming the beneficial effect of a balanced crystalloid in the kidneys. That is probably the reason for that.
Probably both that osmolarity as well as the sodium. Now, while we don't have any literature right now to support that you should target a particular sodium level, most of the times we say maintain normonatremia. Maintain normonatremia, so your sodium of 135 to 145, and then if your patient is getting into trouble, that you're suspecting an ICP crisis or they have worsening cerebral edema, and you're monitoring them closely by their clinical exam, by repeated imaging, etc. So using a trigger to then give a bullet of your hypertonic saline solution, your sodium will transiently rise. You create that osmotic gradient, you dehydrate the brain. It works better than trying to maintain a steady state of sodium. Now, Ringer lactate, we all know, has a lower sodium concentration as compared to normal saline. That's probably one of the reasons why it's also showing us that kind of mortality benefit in subgroup analysis for patients with severe acute brain injuries, but particularly TBI. And although Ringer lactate is isotonic, it is relatively hypotonic as compared to normal saline. So that's probably why. Yeah.
So you talked about a trigger, right? A trigger for giving you hypertonic. So obviously there are clinical parameters, there might be radiographic parameters as well based on which you decide on the trigger. But if you're doing an ICP monitoring, you have an EVD in place or maybe some sort of an ICP monitoring, do you use a particular value to decide that, okay, I need to give this patient a bolus of hypertonic? Or
that's again an excellent question, right? We're classically taught, okay, an ICP of 20 or greater for 5-10 minutes or so, you should treat. And that also varies. There's so much variability, even our definition of what is a clinically significant ICP. The Brain Trauma Foundation guidelines say ICP of 22 or higher, right? And you treat that. And then our subarachnoid hemorrhage guidelines and ICH guidelines will say, okay, maybe you target 20 or higher. The more important thing is, what is the physiology for that particular patient? We also know that ICP dose for different patients is going to be different, and the delta ICP. So where was this patient's ICP? So you have an EBD. There are patients, we've all taken care of them, who have a normal pressure hydrocephalus-like physiology where their ICP is really low, and then their compliance, their intracranial compliance is so, their ventricular compliance is so high that particularly those older patients with big ventricles, in those patients, we can't say wait till the ICP is 20 and then treat. Right? So we're going to augment their CSF diversion even when the ICP rises by a few millimeters of mercury or centimeters of water, whatever you choose to follow, particularly if there's a clinical change or there's a concomitant radiographic change. So while using a number of 20 or 22, whatever number you choose, be consistent in your practice. So and make sure that the bedside nurses, your frontline, team members are aware that, hey, we're going to be treating this number. And particularly if the ICP is elevated for X amount of minutes. So our typical triggers become when we have patients who are undergoing EVD clamp trials, for example. We're clamping their EVD and the ICP is sustained at 20 or higher for 10 minutes, plus minus a clinical change. We're going to say, okay, maybe this patient's failing their clamp trial. So again, using whatever number we choose, we've also got to put it in the context of the patient's physiology. Patients who have infectious etiologies, ventriculitis, whether secondary ventriculitis or that's what brought them in, they can very well have a normal pressure or even negative pressure hydrocephalus-like physiology. So we can't use that number 20 in those patients. But for most adult patients, that number seems to be okay. But there's obviously more literature to talk about this ICP dose, ICP delta for different physiologies.
And I think I'll just ask a final question regarding hyponatremia, because when I was working in the West, people were like really very coy about correcting the sodium fast. It's like they would want the sodium to go up like even slower than whatever is mentioned in the textbooks. They would probably ask for about 4 to 6 and not even go up till 8. So is it still the same practice, or are you okay, comfortable with correcting the sodium faster, given there's some recent literature which says that probably it's not going to cause as much harm as was thought previously?
The approach to hyponatremia, of course, when we think about the chronicity, often we're not going to know whether it was truly acute or chronic, just based on the patient's clinical presentation. And if we don't have a lab value 48 hours prior or a baseline, sometimes it's just hard to tell. Am I dealing with acute hyponatremia? Am I dealing with chronic hyponatremia? Now, hyponatremia in the context of a patient who has any of those severe acute brain injuries, intracerebral hemorrhage, they've got TBM with severe hydrocephalus and cerebral edema. In those patients, are we really going to correct their sodium slowly when they're in extremis and they're developing an isochoria, herniating? The answer for those patients will be no. We're going to do what is needed to save their lives, right? So that's one. In those patients who present with hyponatremia but do not have an underlying brain injury, how do I end up approaching in the context of recent literature? My approach still tends to be a little cautious, where I think it's important to have these patients in a monitored setting, where we're measuring their labs more frequently, where we're correcting, where we're being thoughtful about the correction. Of course, you don't want to over or under correct. By under correction, I mean you don't just want to target like a sodium of 4 to 6 MEQs, but so we'll end up doing about 8 to 10 MEQs in the first 24 hours for these patients, and then treating the underlying cause. It's very important to just keep treating the underlying cause, because the more we treat the underlying cause, the faster someone's going to get better.
Thank you so much, Dr. Neha. If there are any questions, Dr. Tapesh, if you want to ask something.
And I'm also getting called by the unit, so I might jump off as well, but yes.
So we'll just let you go. Thank you so much. Thank you so much for.
There's a question. 1 minute. Dr. Neha, ma'am, 5 minutes. So there's a question. Does the osmolarity of the resuscitation fluids like RL really matter in the background of hypertonic saline mannitol therapy in acute brain injury patients?
Got it. Just give me one moment and I'll be right with.
Yeah.
Sorry, we have a patient with super refractory ICP crisis right now, and the EVD just stopped working.
Okay,
So
ma'am.
we're just fixing that. But in terms of that question, you know, the osmolarity of the resuscitation fluid, Riddhi also asked about drinker lactate versus normal saline. So I do think that relative hyperosmolarity of normal saline perhaps is why we're getting that signal in the subgroup analysis with traumatic brain injury. Are there going to be definitive trials in patients with severe acute brain injuries to show us, you know, balanced solutions versus normal saline? There are a few that are being designed. I don't know if funding agencies will want to fund it. So we'll see.
So there's a second part to that, ma'am, and then we can finish off. Does systemic congestion alter the behavior of venous sinuses in the brain? If so, can we use transcranial Doppler to check the Doppler status of venous sinuses like an extended wave access?
That's such an excellent question. I wish I could say, yes, absolutely, you should do it. I don't know. I don't know if you can. But at the same time, we know that there's going to be venous congestion in various organ beds. There is no reason why it's not going to also happen at the level of the brain. Can we use transcranial Doppler as a marker of venous congestion? It's a little bit harder to say because a lot of these TCD studies are while I'm no transcranial Doppler expert, let me state that, but at the same time, when you look at these TCD studies, it's a little bit harder to interpret venous stasis on TCD. TCDs tend to be much better for understanding arterial abnormalities as compared to venous abnormalities, but certainly something that needs to be studied more.
Great. Excellent, ma'am. Thank you for a lovely talk and all the detailed answers. One small question from my side. Hypertonic saline causes bradycardia and hypotension. So what is the mechanism for this?
Excellent. No idea. Nobody knows so far, including, you know, when you think of what hypertonic saline, that 23.4% concentration is actually doing, it's supposed to give you a positive inotropic effect. And why should it even cause hypotension, bradycardia? And it doesn't happen to every single patient. So one, the mechanism is not known, but at the same time, we also know that if that same bullet is pushed too fast, it could also potentially cause cardiac arrest. That's been described in literature. So what is the safest and fastest way in which you can give it? I'll usually just see how a patient responds to 5 cc's. Sometimes that tells you, you know, are they going to have this bradycardic effect or not? Are they going to become hypotensive or not? And it will just augment their blood pressure. The mechanism is not known, but the effect tends to be transient. You know, it goes away after a few minutes.
Good. Thank you. So, please close it, I think, then.
Yeah. Thank you again, Dr. Neha, for taking time of your busy schedule. I see you're on service.
Yes, I am.
Thank you so much for joining us.
No, great. Thank you so much, guys.
Yeah.
Thank you, Dr. Neha, ma'am. Thank you so much. Wonderful listening to you again sometime.
Thank you. Have a great day.
Yeah, you too.
So I think, Dr. Riddhi, is it so? Any question from the audience on anything on fluids? We can try and answer that. Anything you guys want to know? And I think we have to wait for Professor Malband if he's joining in to kind of give the concluding remarks.
Is he online?
Yeah, he's there, but he's kind of switched off. So let me see.
He might, I can see, he might have. So we should wrap it up here, I think, sir.
But just let me see, you know, if sir can come and give some remarks, otherwise we'll close it down.
Okay, sir. Okay.
Anything you want to add, sir, Dr. Riddhi? You want to kind of expound anything on fluids? People are there, so you can kind of add anything while we wait.
So not really. I think we covered most of the aspects.
It
I was
has
also
been
listening from the morning itself.
You asked some very nice and introspective questions, incisive questions. Yeah.
But the talks were great. Everybody.
So they were, Dr. Robert Han, there's nothing better than him in fluid kinetics, and ma'am is also very well versed with the art of neurocritical care. She's an excellent speaker also. And of course, we had Dr. Kushal, who's coming up, young fellow, but very nicely covered albumin and fluids. Actually, some of the trials are coming up from ILBS. ILBS, Dr. Maiwal is there, and
They're doing a lot of work on liver.
yeah, Dr. Sareen is there, and Dr. Maiwal, Raki Maiwal. Some new trials and new work is coming up from ILBS, including some basic molecular research is also going on there.
They do a lot of work on plasmapheresis and ACLF, and they have a very strong research.
So I think Dr. Malbran is he's logged off, so I think we'll just kind of close it.
Okay.
So, Dr. Riddhi, shall we close it then? I will just want to thank everybody. Thank Dr. Riddhi so much, for really making the session enlightening and very much more interesting. Thanks, Dr. Riddhi Kundu, sir. Lovely.
Thank you, sir. Thank you.
Thank all the audience. Thank Dr. Kushal Kalwit, sir. Wonderful. You covered very nicely, and you cover all the data and all the scientific evidence you put up. Thank you so much. And I thank all the listeners, all the audience, right, from the morning. Many people have joined in various sessions. And I think the total login for this was around 2,000 attendees. 2,000 attendees since morning, and started 10 o'clock and now finishing at 10 p.m. with short breaks in between. So I think we can probably try and get some more collaborative virtual conferences worldwide, and improve the general academic scene, our learning and everybody else's learning. Wonderful to hear from Professor Malbran, and of course, Professor Malbran was instrumental in getting it organized. Great, IFA is a great resource for everybody as far as fluids is concerned. Really thankful to him. Thankful to Dr. Robert Han for his wonderful lecture again. He's a master of fluid kinetics. Thanks to Dr. Neha ma'am, and thanks to Dr. Riddhi Kundu, Dr. Bikash Ray sir, and everybody else who joined in. Thank you so much. And I think with that, we shall close. Dr. Kundu, shall we close? Okay. Bye-bye, guys. Thank you so much. Thank the audience for their wonderful participation. I hope we were able to help you with your education and with your learning. Thank you, everybody. Thank you so much.